Hello everyone. Here we are going to discuss the ultra important topic, that is iron deficiency anemia, also known as IDA. It is one of the most important and most frequently asked anemia in your exams. So either you get long question very frequently on this, and if you are not getting long question, definitely you will get many short questions from this topic. So the etiology, the pathogenesis, the clinical features, the factors affecting iron absorption, and the differential diagnosis, lab diagnosis, treatment, anything they can ask. So let's start the topic. Here you can see iron deficiency anemia, also known as IDA, iron deficiency anemia. So let's start it. So first have a look on the overview, how to write, how to frame your answer in your exam. If it is coming for a long question, don't write paragraphs. No, never write paragraphs in your university exam. You have to frame your answer in neat, clean, following headings and subheadings beautifully with the help of the flowcharts and maximum diagrams. So first of all, write down the introduction. What is iron deficiency anemia? Introduce it. Then to understand the pathogenesis, first you must understand the normal iron metabolism in human body. Then we have to tell you the regulation of iron absorption, then the factors affecting iron absorption. So with all this, you will be able to understand the etiology and pathogenesis of iron deficiency anemia. Then we will see its clinical feature, lab diagnosis, differential diagnosis, treatment, and finally response to therapy. So let's start the topic iron deficiency anemia under these headings. First of all, I will let you know the introduction. It is the most common anemia in the world as well as in India. So most common anemia in the world, it's iron deficiency anemia. Most common anemia in the world as well as in India also, it's iron deficiency anemia only. Now to understand the pathogenesis, first understand normal iron metabolism in human body. Can you see? This is the human normal digestive tract we have drawn. Now imagine this is a healthy human who is consuming, eating intake of iron via oral route. So we all take iron in the diet, whether the vegetarian or the non-vegetarian. In both the diets, iron is always present. So in vegetarian diet, it is present in green leafy vegetables. It is present in jaggery. In the non-veg, it is present in meat, especially red meat is the highest, richest source of the iron. So whether you are eating veg or non-veg, the iron you are eating, whatever iron you are eating, it is Fe3 positive. So in the diet, the iron is present in Fe3 positive. Now this iron will go inside in the mouth, in the esophagus, in the stomach, and in the intestine. So you can see here is the intestinal cell, which is known as enterocyte. This is the intestinal cell, which is known as enterocyte. This enterocyte will absorb the iron from the lumen of the intestine into the blood. So you can see, look at the arrow. I want to absorb the iron. I want to absorb the iron like this. So the iron, I want to absorb the iron from the lumen of the intestine, into the blood vessel. So this iron has to cross this cell. So for this, two transporters are required. The first transporter is present here. Can you see here on the luminal surface of this cell? On the luminal surface, can you see this transporter? Let me highlight this cell. Now see the luminal surface of this cell. This transporter is known as DMT, that is divalent metallic transporter. So this is the first transporter. It takes the iron from the lumen of the intestine inside the cell. So it is transporting like this. And second transporter is here. You can see this one is known as ferroportin. It is known as ferroportin, FP, ferroportin. It transfers the iron from the lumen of the inside the cell into the blood vessel. So there two transporters are required, but there is a problem. What is the problem? Let me tell you what is the problem here. The problem is that the first transporter, which is present on the luminal surface. What is the name of that transporter? This transporter is DMT, divalent metallic transporter. Can you see this transporter is DMT, divalent metallic transporter? As the name indicates, it's divalent. It transmits only Fe2 positive. All the divalent ions, it do not transmit Fe3 positive. So whatever we are eating in the diet is Fe3 positive. But if it want to get absorbed, it has to convert into Fe2 positive. So who will convert the Fe3 positive to Fe2 positive? So before the iron get absorbed, we have to convert ferric iron to ferrous iron. Fe3 positive is ferric. We have to convert it into ferrous. So Fe3 positive has to be converted into Fe2 positive by hydrochloric acid present in the stomach. So HCl or hydrochloric acid, which is present in the stomach, it will convert Fe3 positive to Fe2 positive. This Fe2 positive will come in the lumen of the intestine, and now it will get absorbed. So DMT will take it from the lumen inside the cell, and ferroportin will take it from inside the cell into the blood, but ferroportin again oxidize it. So again it will convert Fe2 positive to Fe3 positive. So my point is that the summary is that whatever we eat in diet is Fe3 positive. Whatever reach in the blood is also Fe3 positive, but only for conversion purpose, only for absorption purpose, it got converted to Fe2 positive. So whatever we eat is ferric, whatever reach in the blood is also ferric, but for absorption purpose, it converted into ferrous, you can see. Now, once it is reaching in the blood, ultimately it reached the blood. Now, once it is reached the blood, it do not travel by its own. It needs a transporter. I always call the transporter a scooter. Can you see the scooter of iron? The iron will sit on its scooter and drive. So it is a scooter of the iron, you can say, or it is a transporter. You can say it's the vehicle, it's the car of the iron. So on one scooter, two people can sit. So on one transporter, two iron molecules can sit. What's the name of this transporter? This is known as transferrin. The name of the transporter is transferrin. Transferrin is the transporter. So it is transporting the iron from the site of absorption throughout the body. So throughout the body it is going, but iron is required only at one place. Why we require iron in human body? What is the function of iron in human body? Iron is required for synthesis of heme of hemoglobin. So in hemoglobin, we need iron to synthesize heme. Hemoglobin is made up of two things, heme and globin. Globin is protein, but heme is iron. Heme is made up of iron. Okay, so it is required in the bone marrow. Inside the bone marrow, we are having erythroid precursors. Can you see these all are erythroid precursors? The pro-normoblast, early normoblast, intermediate normoblast, late normoblast, they all synthesize heme. They will take the iron. So this is the iron present in the blood. They all will take it. They all will take it and convert the iron into the heme because they have the enzyme for converting iron into heme. The name of the enzyme is ALA. Okay. Now they will convert and they will form the heme. Okay. Now any extra iron, if any extra iron is present, that will go to the liver and stored in the liver. The storage form of iron in the liver is known as ferritin. So ferritin is the storage form. So here you get two questions, one-liner question. Who is the transporter of iron and who is the storage form of iron? So transporter of iron is transferrin and the storage form of iron is ferritin. So please learn transferrin and ferritin. You get questions on that. So this is the normal story we have learned. We can write this in the form of the flowchart. Please read it. Whatever we are eating in diet, whether veg, whether non-veg, whatever is the diet, iron is present in ferric state in all the diet. Okay, now but we have to convert it into ferrous state before it get absorbed. So HCl, hydrochloric acid, convert the iron from ferric to ferrous. So more is the acid, more is the conversion, more is the absorption. So if you want a better absorption of iron, the acid in the stomach should be more. If the acid in the stomach is less, absorption of iron will not occur. So this is because acid converts ferric to ferrous, Fe3 positive to Fe2 positive. Now it will go in the intestine. In the intestine, the luminal transporter is DMT. What is DMT? Divalent metallic transporter. It will take the iron from the lumen of the intestine to inside the cell. After going inside the cell, there is another transporter. The another transporter is the basolateral side. It is known as ferroportin. It will transfer the iron from inside the cell into the blood. So first from the lumen to the cell and from cell to the blood. This is ferroportin. But ferroportin again oxidizes it from ferrous to ferric. So whatever we eat is ferric. And whatever reaches in the blood is also ferric. But only for absorption purpose it got converted to ferrous. Now iron required transporter to move from here to there. So who's the transporter of iron? So please see, transporter of iron is transferrin. I call it scooter. Transporter. T40. So transferrin is the transporter. So it will give all the iron to the marrow, the bone marrow. So whatever is required in the bone marrow, the erythroid precursors will take it and they synthesize heme out of it. Whatever extra iron is there, it will be given to the liver and it will be stored in the liver in the form of the ferritin. So ferritin is the storage form of iron. So please learn who is the transporter of iron and please learn what is the storage form of iron. You get one-liner question or very short question on both of them. So transporter of iron is transferrin. And the storage form of iron is ferritin. So please learn. You get one-liner question or very short question on that. Now, coming on the regulation of iron absorption. How does the iron absorption is getting regulated? So in the liver, I told you, extra iron get stored in liver in the form of the ferritin. Whenever in the liver ferritin is too high, abundant of storage, we don't require more iron in diet. So what the body will do? So liver will synthesize a molecule. The name of that molecule is hepcidin. Liver will synthesize hepcidin and release it in the blood. So hepcidin is synthesized by the liver. It will go in the blood and via blood it will go and it will destroy the ferroportin. It will destroy the ferroportin, the basolateral transporter. Now what will happen? The person will eat the iron. It will go inside, but it cannot be absorbed. It will be excreted in the feces. It will not absorb. It will excrete it. It will go inside the cell, but after the cell will rupture, it will come in the feces. Okay, so it will not come in the blood. Why the body is doing so? Because it is already excess of iron in the liver. We don't require more. So whatever extra iron the person is eating, the body is not taking it. The body is excreting it in the feces because hepcidin is destroying the ferroportin. So when iron is in excess, hepcidin is high and absorption is low. Okay, but imagine the reverse situation. Now imagine the ferritin content is very low. In the liver, hardly any ferritin is there. There is no storage at all. So body want the iron to get absorbed. So hepcidin will stop. Hepcidin synthesis will stop. Hepcidin will not release in the blood and ferroportin is reactivated and more iron absorption is there. So when storage is less, hepcidin is less, absorption is more. So this is the thing. So what we have learned this thing. For the iron regulation, the same story is written in front of you. So whenever the iron stores are high in the liver, intrahepatic iron levels are very high. The ferritin is very high. Liver synthesized hepcidin. Hepcidin go in the blood and it will bind to the ferroportin and degrade the ferroportin. Ferroportin is non-functional, so iron will not get absorbed. Iron is excreted in the feces. It inhibits the absorption of the iron from the cell to the plasma. So iron will trapped inside the cell and it will be, when the cells are sloughed, it will be lost in the feces. So iron absorption is not there. You can see the same. So whenever the body is having abundant store of iron, hepcidin is secreted in the blood and absorption will be low. But whenever the body have low stores of iron, hepcidin synthesis is falling. There is no hepcidin synthesis and absorption increases. So hepcidin is inversely proportional to absorption of iron. Whenever the hepcidin is high in the blood, the absorption is low. And whenever hepcidin is low, the absorption is high. And who will decide hepcidin? The liver will decide hepcidin. I hope you got it. So I told you two possibilities. When ferritin or the storage of the iron is too high, so the liver synthesizes hepcidin. And in that case, hepcidin is high. And hepcidin will degrade the ferroportin and absorption is low. So see, when storage is high, hepcidin is high, absorption is low. Okay, now see the reverse situation. Imagine when the storage is low, when hardly any ferritin is there. So there is no hepcidin. There is zero hepcidin, less hepcidin. So the absorption will increase because the ferroportin is regenerated. So when the storage is low, hepcidin is low, but absorption is high. So same story is written in front of you. This is known as regulation of iron. So who's the transporter of iron? Transferrin. And who's the storage form of iron? It's ferritin. The aggregates of ferritin is known as hemosiderin. I hope you got it till now. Okay, so this was regulation. Now coming on the factors of iron absorption. So tell me the factors which increase iron absorption and tell me the factors which reduce iron absorption. You get short or very short note on that. So you tell me iron get absorbed in ferrous form. I told you na, because of DMT, divalent metallic transporter. So ferrous iron increased absorption and ferric reduced absorption. For converting from ferric to ferrous, HCl is required. So all acid increase absorption and absence of acid. Achlorhydria is absence of acid, decrease absorption. So acid HCl increases and absence of HCl decreases. Ferrous increases, ferric reduces. All acid, not only HCl, ascorbic acid, amino acid, these are also acid. So they will also increase the absorption. And all the alkaline food will reduce the absorption. You know what is ascorbic acid? Ascorbic acid is present in the citrus fruit. Have you seen the lemon, the orange, all the citrus fruits are there. So in all the citrus fruits, ascorbic acid is present. So my mother always says that whenever you are eating spinach, always mix lemon with that. So I don't understand why. So because spinach contain iron and the lemon contain ascorbic acid. So if we take the two together, the absorption of iron will be better. So if I'm taking the iron and along with that I'm taking the acid also, so that iron will get converted into from ferrous to ferric very quickly and absorption will be better. So whenever you are taking any iron diet, mix it with the acid. Ascorbic acid is the best thing. So you can sprinkle the lemon over the anything which contain iron like the spinach or green leafy vegetables. Okay, so ascorbic acid, amino acid, they increase and alkaline food they reduce. And the phytates, tannates and phosphates, they form chelates with the iron. That's why they reduce the iron absorption. So please learn the factors which increase iron absorption and learn the factors which reduce iron absorption. It's very easy to learn. Increased absorption is ferrous and decreased absorption is ferric. HCl increase absorption and no HCl, absence of HCl, that is achlorhydria, is reduced absorption. Okay, all the acid increase absorption like ascorbic acid, amino acid, and the alkaline food will reduce the absorption. Apart from that, phytates, tannates, they form chelates with the iron and they reduce the absorption. So you have to learn these factors. You get short or very short note on that. Now what is the etiology of iron deficiency anemia? Etiology means causes. What are the causes of or risk factors of iron deficiency anemia? There are four etiology. Either the person is not eating iron in the diet. Imagine a person who is not eating the iron in the diet. You will say, ma'am, why the person is not eating? Maybe the person is very infant, the diet is not good. In children, they are very fuzzy in eating, they are not eating the good diet. Or the person is very poor, patient, but person cannot afford iron. And person is very elderly, the dentition is the problem, person don't have the dentition. Due to poor dentition, person cannot eat it. Whatever is the reason, person is not taking enough iron in the diet, so person will have iron deficiency anemia. One thing. The second cause, the person is having adequate in the diet, but there is a problem in absorption. The absorption is not there. Dietary is good, dietary intake is good, there is no problem in that. The problem is in the absorption. So the first thing, the dietary intake is not good, and second, dietary is good but absorption is not good. Why that absorption is not good? The patient have diarrhea, gastrectomy, spruce, steatorrhea, there is some problem in the intestine, so absorption is not good. The third cause, dietary is good, absorption is also good. So the iron the person is taking, it is reaching in the blood. You will say, then what is the problem? You are saying diet is also good, in the amount is also good, and dietary intake is good, and the absorption is also good. So the problem is that requirement is more. So although iron reaching in the blood, but it is more required, like in pregnancy, like in growing infant, like in premenstrual female. So requirement is more. So again, there will be a deficiency. And last, there is chronic blood loss. So imagine a person in which there is peptic ulcer, gastric carcinoma, hemorrhoid, UTI, hematuria, or any cancer in which there is bleeding constantly. So person is eating well in the diet, absorption is also well, requirement is also normal, but since person is bleeding constantly, it will cause iron deficiency anemia. So what are the causes? What are the four etiology? What are the four causes of iron deficiency anemia? Can you tell me what are the four causes? Very easy. Number one, dietary intake is not good. Number two, dietary intake is good, but absorption is not good. Number three, dietary intake, absorption, both are good, but the requirement is more. Either dietary intake is less, or absorption is less, or requirement is more. These are the three. And fourth is blood loss. So learn the four causes or the four etiology of iron deficiency anemia like this. Please learn that. So either decrease dietary intake, or decrease absorption, or increase requirement, and last one is blood loss. Constant blood loss due to any reason. So these are the four causes. Now coming on the clinical features, the patient is having fatigue, lethargy, you can see patient can have palpitation, pallor of the skin, loss of energy, tiredness, because person will feel lack of energy. So that is the generalized features. Now coming on the specific features, the nails become spoon shaped. Can you see normal nails are flat? See my nails, they are flat. But here the nails become spoon shaped. There will be a concavity in the nails, so it is known as spooning of nails. There is a concavity in the nails, that is spooning of the nails. It is known as koilonychia. What it is known as? Spoon shaped nails are known as koilonychia. Nychia is the nails, koilo is the spooning, koilonychia is there. See the tongue, normal tongue is glossy, shiny. See the tongue in the patient with iron deficiency anemia, it's atrophied. So the tongue is atrophied. And see the angles of the mouth. At the angles of the mouth, there may be inflammation. It is known as angular stomatitis. So say the three epithelial changes. The nails become spoon shaped, that is known as koilonychia. The tongue, normal tongue is shiny, but here the tongue become atrophied, and the angles of the mouth can have inflammation, that is angular stomatitis. So see, these are the epithelial changes. So see the general features, see the epithelial changes, and there is a syndrome associated with iron deficiency anemia, that is known as Plumber-Vinson syndrome. Here three things happen together. The person have iron deficiency anemia, the person have VAPs in the esophagus. In the esophagus, persons have VAP. That's why person can't eat, and person have dysphagia, and this is the reason person have iron deficiency anemia. So the three things occur together. Start with the VAP. Person have VAP in the esophagus. Imagine the esophagus. The esophagus is having VAPs. So there is constrictions in the esophagus. The person have difficulty in swallowing. Person have painful swallowing. That is known as dysphagia. And since person is eating less, so person will have iron deficiency anemia. The three things together known as Plumber-Vinson syndrome. So these are the symptoms we have seen. We have seen general symptom, we have seen epithelial symptom, and we have seen a syndrome, that is Plumber-Vinson syndrome. So these are done. Now finally the lab diagnosis. The lab diagnosis of iron deficiency anemia. So in all the anemia, whatever anemia you see my lecture, my video on any anemia, lab diagnosis is in a fixed protocol. So we will have blood picture, bone marrow picture, and biochemistry. In all the anemias under these headings only, I have discussed the lab diagnosis under the particular sub headings only. So the protocol is very fixed. So you have to fill it just. Okay. So in the blood, we will see six things: hemoglobin, RBC morphology, retic, the three indices, that is MCV, MCH, MCHC, WBC and platelet. So comment on them. Of course, the hemoglobin will be less. In all anemia, hemoglobin less. So here also hemoglobin will be less. What about the RBC? RBCs are small and having less color. So the RBCs are microcytic and hypochromic. Can you see? This is a normal RBC. And this is a RBC in iron deficiency anemia. Appreciate the size is less and appreciate the color is also less. Hardly any color at the periphery. So microcytic, hypochromic RBCs are there. Variation in size is there, variation in shape is there, and target cells are there. So that is the blood picture. Can you see the blood picture? Appreciate the lymphocyte in the blood picture. Where is the lymphocyte? You all can see this is the lymphocyte here. Now appreciate the size of the RBC with the lymphocyte. I can see most of the RBCs are smaller than the lymphocyte, so they are microcytic and hardly any color at the periphery. So they are hypochromic. Normal RBC, the peripheral 2/3 is colored and central 1/3 is palar. Here palar is expanding. And most of the cells show target cells also. So you can say that. Okay, you have to draw this picture. The retic count will also fall because retic is the precursor of RBC. RBCs are less formed. The retic is also less formed. MCV, MCH, MCHC all will diminish. But the platelet and the WBCs are normal. There is no problem in platelet and WBC. So hemoglobin will fall. RBC shows microcytic and hypochromic. Rather than writing, you have to draw it. Microcytic, hypochromic RBC with target cell. Retic will fall. All the three indices, MCV, MCH, MCHC will fall. WBC is normal, platelet normal. So this is the blood picture. Coming on bone marrow picture. Tell me the cellularity in the bone marrow. Since the RBCs in the blood are less, so bone marrow will try to compensate and synthesize more and more and more RBC. So cellularity is high. And most of the cells are erythroid hyperplasia. There is erythropoiesis. There is no megakaryopoiesis or granulopoiesis. There is erythropoiesis. And the marrow iron is deficient. So that is the bone finding. Cellularity is high, erythropoiesis is high, and marrow iron is depleted because it is iron deficiency. In biochemistry, you have to learn the four things. So coming on the biochemistry. You tell me the person is not eating iron, either the dietary deficiency or the person is eating, but absorption is not good. Ultimately, in the blood, iron is less. Iron is less in the blood. Iron is less in the blood. Okay, now imagine if from today, I will not eat iron in my diet. So from today only I will have iron deficiency anemia. You think and tell me from today or after how long I will have iron deficiency anemia. From today I'm not eating iron in my diet, absolutely not eating. Or I'm eating but absorption is zero. Absorption is zero. So due to any reason, my blood do not have iron. You can say, no ma'am, you don't have iron deficiency anemia, you have backup now. I'm having liver and in my liver I'm having abundant of ferritin. So I'm having reserve of 2-3 months. So at least for 2-3 months, if the marrow is not getting the iron from the intestinal absorption, it's okay. The backup will be given by the liver. So liver will give the backup. Liver will keep on giving the iron to the marrow, keep on giving the iron. So heme will be synthesized, hemoglobin will be synthesized. For the next 2-3 months, I will not have any symptom. But one day will come when the completely ferritin will also get depleted. Okay, now the dietary intake is zero or the absorption is zero and the ferritin is also zero. So what will happen now? Who will give iron to the marrow? Nobody is giving iron to the marrow. Neither it is coming from the intestinal absorption nor it is coming from the liver. So marrow is not getting the iron. So marrow is not getting the iron. So there will be, the erythropoiesis will not be effective. Ineffective erythropoiesis will take place and that will lead to iron deficiency anemia. So here the hemoglobin will fall later on. Before the hemoglobin fall, ferritin fall. So the most sensitive indicator for iron deficiency anemia is ferritin. So we come to know we have anemia when we see the CBC and in the CBC hemoglobin will fall. But before that ferritin start falling. So the most sensitive indicator of anemia is ferritin. Just suppose I'm having a person in my clinic and I check the ferritin level. The ferritin level are less. But in the CBC hemoglobin is normal. Hemoglobin is 13, 14 gram maybe. It's normal. So the person is not anemic right now, but soon the person will become anemic because ferritin started falling. So ferritin is the most sensitive indicator of anemia. That is my point. You have to learn the most sensitive indicator for iron deficiency anemia is not hemoglobin. It's not anything else. It's ferritin because ferritin is the earliest that will fall. As soon as the person stop eating or stop absorbing the iron, the ferritin start falling because ferritin is the backup. So that you have to learn. So what will happen in iron deficiency anemia? Comment on two things. What happened to the iron level? What happened to the ferritin level? The person is not eating or the person is eating but it is not absorbing. In any ways, in the blood, iron is low. Obviously, iron is low. And the ferritin in the blood will also start falling. So ferritin will also fall. So iron will fall and ferritin will fall. So iron fall, ferritin fall. I guess you can understand by looking at this diagram. The iron is less because person is not eating it. And ferritin is less because it is giving the backup. So it will also fall gradually, its level will decline. So both of them are falling. Now two things you have to understand here. What is TIBC? Total iron binding capacity. And what is transferrin saturation? You have to understand it. Here I told you who's the transporter of iron. Can you tell me the transporter, the vehicle, the scooter? Who's the scooter of iron? You all can see this is the scooter of the iron. This scooter is known as transferrin. Transferrin is the scooter of iron, as I told you. Say yes or no. So on one scooter, two molecules of iron are sitting. This is transferrin. Okay. Now in adult human being, how many transferrin are present? We talk transferrin in terms of percentage. Okay, so we will say 100 transferrin. I will not draw 100, but I will draw 10. For understanding, I will draw 10. But imagine if they are 100. Okay, imagine if they are 100. So at a time, how many are filled? These are the scooters. These are the vehicles. This is the transporter of the iron. So on one, two molecules of iron are sitting. So at a time, 33% are filled. At a time, at any time, you check in me, you check in yourself. In an adult human being, 33 are filled at a time and 66 are empty at a time. This is normal. This is normal. Okay. So the filled one are known as transferrin saturation because they are saturated. You will say, yes, ma'am, we can understand. So transferrin saturation is 33% in adults, in humans, in adult healthy humans. So that is the filled one. What are the empty one known as? The empty one are known as TIBC. What is the full form of TIBC? You say, you will understand. It's transferrin iron binding capacity. What's the meaning of capacity? If I say I'm having a capacity to teach for 24 hours continuously, I'm not taught 24 hours continuously till date, but I have the capacity to do so. I mean, capacity is something that is not yet captured, but we have a capability to do so in future. So that is the capacity. So transferrin iron binding capacity, that is the empty one. So TIBC is 66%. So this is normal. This is normal. Now you will tell me what happens in iron deficiency anemia. You tell me what is happening normally. And you tell me what is happening in IDA, iron deficiency anemia. Use your brains and tell me. So normally, what is transferrin saturation and what is TIBC? And in IDA, what is transferrin saturation and what is TIBC? I guess you can understand these are the filled one and these are the empty one. The filled scooter and the empty scooter. These are the filled one and these are the empty one. Now use your brains and tell me. Here, the filled one are 33% and the empty one are 66. Normally, I told you like this. Here, iron is less now. So scooters are empty. So most of the scooters are empty. So here, the TIBC will increase and the filled one are the less. So transferrin saturation will fall. So I don't think you have any confusion here to understand. I hope you got it. So same thing is written. The TIBC will be high. These are the empty one and the filled one will be low. And the diagram is shown to you. You can see the black colors are the scooters I am talking about. These are the transferrin. These are the scooters. On one scooter, you can see two molecules of iron are sitting. So the filled one are transferrin saturation and the empty one is TIBC. In iron deficiency anemia, the filled one will fall and the empty one will rise. So that is the biochemistry. So I guess we are done with the lab diagnosis. Can we revise it? Complete lab diagnosis at one shot. Learn this and fill it quickly. So what happens in the blood picture? Say ma'am, iron, hemoglobin will fall. RBCs are microcytic and hyperchromic. The retic will also fall. All the three indices MCV, MCH and MCHC will fall. WBCs are normal. Platelet is normal. This is how I will fill and I will write the reason for each of them. In the bone marrow picture, the cellularity will be high to compensate. Most of the cells are erythroid precursors and the marrow iron will fall because there is iron deficiency. Now, most important is the biochemistry picture. Here, iron is less, ferritin is less, transferrin saturation is less, but TIBC is more. TIBC is the empty rickshaw, empty scooters. I hope you all got it. Okay. Now, the differential diagnosis. How many anemias have microcytic hypochromic picture? Iron deficiency anemia, SITA. The mnemonic is SITA, SITA. These are the four anemias in which there is microcytic hypochromic picture is there. Microcytic anemia is there. Sideroblastic anemia, iron deficiency anemia, thalassemia, and anemia of chronic disease. So if I say what are the differential diagnoses of iron deficiency anemia, so remaining three are the differential diagnoses because they all have microcytic hypochromic picture. But with other tests, we will identify what is the type of anemia. So the differential diagnoses are always four. S, that is sideroblastic anemia. I is iron deficiency anemia. T is thalassemia and A is anemia of chronic disease. So you have to learn the differential diagnosis and you can understand this table because each of them have a separate video. I wish you are watching all these videos back to back together so you will have a better understanding of this table. Okay, now treatment. What is the treatment of iron deficiency anemia? Common sense. Iron is deficient, you have to give iron. But before that, treat the cause. If you don't treat the cause and give iron directly, again the person will have iron deficiency anemia. For example, there is problem in absorption. You're not treating the problem. There is some problem in the intestine. There is problem in absorption and you are giving the iron. So if you're not solving the problem, it will happen again. So first solve the underlying cause and then give the iron. For correction, give the iron. There are two types of iron therapy. Orally in the form of the tablets And parenterally is given directly IV. We can give the iron. Okay, so parenteral therapy can also be given. So in the oral, three type of preparations are available. Ferrous sulfate, most commonly used, ferrous fumarate, and ferrous gluconate. So there are three type of preparation: ferrous sulfate, ferrous fumarate, and ferrous gluconate. Three type. Most commonly ferrous sulfate is used. So these are the tablets. Okay, and in the when usually we give tablets only, but when we give the parenteral therapy, when the person is having intolerance to oral therapy, the person cannot tolerate the oral therapy, whenever there is a malabsorption, whenever there is post-op cases, or whenever rapid replenishment is required, like the person is going to be delivered, the female is pregnant and the next day she is going to deliver and she is severely anemic, so we give parenteral therapy. And here only one preparation is there: iron dextran, that is given parenteral. That's all. So whenever you give the therapy, the earliest response to the therapy is the increase in retic count. So as soon as you give the therapy, the very next day the patient will have, in 1 or 2 days only, the patient will have increased retic count. So that's all about it. So if a long question is coming on iron deficiency anemia, you have to write down everything. So please, I insist the students to learn the overview. And if particular thing is asked, they are asking only factors, write that. If you are asking only pathogenesis, write that. If they are asking only clinical feature, only diagnosis, write that portion only, in short or very short. But if it is a long question, you have to write down everything and you have to judge by timing. So you have to fix that you will give 30-minute or 20-minute, whatever, to this answer, and you have to divide your answer in your mind before you start writing under the headings. So that is the way you should score good in your university exam. That's all about it. Don't forget to check all the long question, short question, very short question and MCQs of this topic, which are given in notes and question bank section. Thank you.